Martin Luther King Jr. challenged injustices across all levels of American society, including health care. And Eyewitness News reporter Annabelle Munoz spoke with some physicians who reflect on his work and a shared mission.
Dr. Susan Rogers remembers when Dr. Martin Luther King Jr. visited her hometown.
When I was in 7th grade, Dr. King came to Chicago to march against the segregated neighborhoods that he found were just as bad in the northern cities like Chicago as they were in the Deep South.
According to the Associated Press, it was also in Chicago that Dr. King said, of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. It was at a news conference in connection with the Medical Committee for Human Rights.
The situation of healthcare in this country was abysmal for minorities, segregation of hospitals.
Dr. Rogers is now president of Physicians for a National Health Program. Alongside colleagues like Dr. Paul Song, who leads the California chapter, the group advocates for a more just system through Medicare for All.
Physicians for a National Health Program was actually founded by a doctor by the name of Quentin Young, who was actually, ironically, Martin Luther King's physician. Dr. Young, during the riots and also during the protests, organized a group of doctors to basically go down to all the freedom marches to really help if anyone was injured during those marches to provide medical assistance. A lot of disadvantaged communities, while we may have achieved equalities in one way or another, that with regard to healthcare, it's still grossly, there's a gross divide.
And many of those inequities have been exacerbated here in Southern California during the pandemic.
One of the things that COVID did highlight was how your life expectancy is more determined by your zip code than your genetic code.
I think right now in California, we face a very pivotal moment. We still have roughly 3 million people that are uninsured. We have millions of people that are underinsured, meaning even though they have a piece of paper that says they have insurance, that their copays and deductibles make it so expensive that they can't seek the care.
Those hardest hit are often frontline workers and people in low income and communities of color.
Dr. King's words have always resonated with me, and I think he really goes back to the book of Matthew about caring for the least among us. That we're not defined by how many billionaires we create in society, but really about how we care for the most marginalized, our poor brothers and sisters, really those that don't have a voice in our society.
What a great video. Good afternoon, everyone, and happy Friday. I am Dr. Tonya Roberson, the chair of the Far South Chicago Coalition's Health and Mental Wellness Committee, and your host for our Friday Health Talk of the Week. The Far South Chicago Coalition is comprised of caring community leaders, business owners, and engaged residents working together to make a change and to create a thriving community. I am happy to announce that with your help, the Far South Chicago Coalition has created 9 key focus areas that has helped us create the amazing Far South Chicago Quality of Life Plan. We are one band, one sound, and we deserve the best. Thank you for joining our show today entitled Faces of Change, Doctors as the New Generation of Community Leaders in the COVID Crisis, Resounding Dr. Martin Luther King's Wisdom. There are many people in our communities that we consider role models and leaders, and doctors are one of them. They are well respected and have the medical education that can help us all. They are in contact with different people at different times. They help many people, and many see the good in the work that doctors do, and they listen to what their doctors say. Reflecting on the past 2 years of the pandemic and celebrating Dr. Martin Luther King's birthday this past Monday, much research shows that the COVID-19 crisis has disproportionately impacted the health and economic well-being of underserved communities, including many Black Americans. Today we have two community champions whose strategies and philosophies embody the work of Reverend Dr. Martin Luther King Jr. and what he famously said in his 1963 letter from a Birmingham jail. Whatever affects one directly affects all indirectly. So I will turn it over now to our moderator, Mr. Ted Williams III, who will introduce our guest.
Thank you so much, Dr. Roberson. Thank you for pulling together these wonderful programs to really educate and inspire our community. You know, here at the Far South Chicago Coalition, folks, we celebrate Dr. King's holiday not just on Monday of this week, but all through the week, all through the month of January, and really all through the year, because we are trying to live out the principles that he lived for and ultimately that he died for. And so we're just happy that you were here. Please tell someone if you are hanging out with us on this Friday afternoon. Call your friends, your family, tell them you're going to learn today about this COVID-19 crisis, and we're going to hear from the truth from real practitioners, from doctors. And please spread the word about what we do every Friday at 2:00. We are on, and we are letting people know what is going on in our community. So today we have two phenomenal panelists. I want to go ahead and introduce them. We have Dr. Sandra Coker, who is with the University of Chicago's emergency medicine. She's an emergency medicine resident, and she's a community champion. And we have Dr. Molly Leavitt, who is an internal medicine resident, and she's also a part of their community champion program as well. Welcome, doctors. How are you all today?
Thank you. Thanks for having us. Thanks for having me. Doing well. Happy New Year, everybody.
Fantastic.
Well, thanks for having us.
Fantastic. So I'm just going to start with some simple stuff here, because we're going to really get into some data and talk about kind of what's going on in our communities. But I wanted to ask you guys just a simple question. How on earth did you all get into this career field that is part, I believe, sort of job and really part calling, right? And so this is this vocational concept. I don't think you get into what you do for a living just because you're looking to make a living. You really have to have a heart for this. And so I'd love to hear from both of you, sort of how did you get into this work?
Yeah, I think for me, I was one of those people who knew I wanted to be a doctor since I was, in elementary school. I always really liked science class. I liked biology class. Those are always my favorites. And I knew I wanted a career working with people. So it wasn't a big leap for me to start deciding that I was interested in medicine. I kind of pursued it through some classes in high school and then in college, and then went to medical school. Chose a career in internal medicine, which is basically kind of all of adult medicine, because I have an interest in how all of your different health problems work together and helping a person as a whole. That's how I ended up here.
Yeah, and similarly, I was definitely also the student in elementary that was like, I'm going to be a doctor. I had never seen a doctor that looked like me. I didn't have a doctor in my family, but I knew somehow, some way I was going to be a doctor. My mom was in the healthcare field, not a physician, but in the healthcare field or associated with it. So we spent a lot of time, as she was a single mother, with her at work. We spent some nights on the hospital floor and like some workrooms and work closets sleeping. And I was always the kid that like ran out and was just like running up and down the halls of this hospital, this like long-term care facility that she worked in. And my interest was like sparked from just a super young age. And I was pretty determined, as I am with everything in my life, to like, this is what I say I'm going to do, and I'm going to do it. I think more interestingly, the question is like, what led me to Chicago? Because I didn't always know I was going to come to Chicago. Didn't know I was always going to come to this specific community. But going through college, I began to see the healthcare disparities and inequities that directly affected and challenged people who look like me. I began to have a harder time finding people that would mentor me, people that would show me the ropes, people that would point me in the right direction. And I kind of had to do everything for myself. So I was, becoming more aware of these things that just weren't I don't know, these challenges that were unique to African American communities. And that sparked my interest in studying more about healthcare disparities and communities like the South Side of Chicago. And so when I learned about, when I chose emergency medicine as my specialty, really because we're a safety net for the community, because we, our doors are always open. We always accept all patients. We treat every patient the same. When I started thinking about where I wanted to go, I was very intrigued by Chicago, given the history, in this community. And I wanted to find any way that I could get out here as soon as possible and get my feet on the ground and my hands dirty and try to give back to the community and serve the community the best way I knew how.
That's awesome. Thank you all for sharing your stories. I think it's really important to know where people are coming from. I think it helps to kind of know where they're going, right, and what they're doing at this time. And I just want you all to hear this at home, ladies and gentlemen. She said that she couldn't wait to get to our lovely city. And, we get a bad rap in the news sometimes, and people are always talking about, the challenges that are here. But there are people that who want to be here, I personally was living on the East Coast. I was in college, and I decided to come back here to go to graduate school. And yes, I too wanted to come here because Chicago is such a great city, and we have to remember that. And we have to fight for the city, right? Because it's such a great city. I think that we have to continue to push. So anyway, so we're going to talk about COVID today. We talk about COVID a lot. Everybody's about COVID, right? We're talking about COVID, but I think it's so critical that we really understand. And Dr. Roberson really wanted to have this conversation about the role that doctors are playing today in a very different way than what you might have been playing 5 years ago. She pinned this conversation, doctors as community leaders during COVID. Can you tell us how your role has potentially changed, if at all, in the last couple of years? And why do you think that we're talking about doctors as community leaders during this time?
Sure. So I think in terms of knowing where we're coming from, so both Dr. Coker and I started residency in the midst of the beginning of COVID. So COVID had been going strong for about probably 3 or 4 months when we jumped in and started in University of Chicago. So our role as MDs has always been in this pandemic. What we did get to see beforehand was the roles of our mentors, the roles of people who we were watching in medical school. And it really is a different career, I think, than we were expecting in medical school because of COVID. I mean, for one, we're seeing people who are sick because of COVID and having to take care of these patients, and seeing people who may have or may not have gotten vaccines, people who have misunderstandings about what's going on. I think there's always been an issue of kind of a lack of sometimes clear information in healthcare and a lot of misinformation in healthcare. But the COVID epidemic has just really, really expanded that. So we are, as clinicians, kind of one of our roles is to help fight that misinformation. That's something that I think I didn't realize I would be doing when I decided to become a doctor, but something that's become so important, and that fighting that misinformation, for one, takes place in clinic. I see a lot of patients who come in to see me outpatient and are coming in for their checkups, and it's really important at that time to address anything they may have heard that maybe is correct, but maybe is also incorrect, and using that as a safe space to talk about, what can we do to better your health, and what are things that are science-based and proven to help you stay safe from COVID and other diseases. And then I think it's also, our role is also expanded to fighting that misinformation at a broader level. So using the platforms that we have, be that, things like this, family members, social media, whatever it may be, to really say, hey, we have studied this, we're doctors, and this is the information that is true, and this is the information that is studied in the science, as opposed to the information that's not.
I got to stop you right there. The fact that you got to remind people that you're doctors during this it just is crazy. Like, yeah, I know what you read on the internet, but I'm a doctor. I kind of studied this for a while. I've been doing it. You might want to hear what I have to say. I mean, Dr. Coker, are you equally surprised by kind of this climate that we're in?
100%. I couldn't agree more. Exactly what you guys just said is exactly how I feel down in the ED. We're the first stop for everybody who gets sick and everybody who comes in. Or people are just curious and sometimes just end up in the emergency department. And we are having to, remind people that, hey, I understand what, the media is propagating. I understand what your family member may have told you. I understand that myths in the Black community run very deep. I was a part of this is totally a side comment. I was part of a separate project that combated myths regarding sexual health and STI and HIV transmission among African Americans. And the number of myths that we have just embedded in our communities, things that, our grandmothers used to tell us, or our cousins used to come, by the house and tell us, like, this is how you get this, and this is how you stop this, and this is how you treat this. And if you just drink this, this will go away. It's just a bunch of that we're having to do again, right? It's a bunch of that we're having to do with patients who are coming in younger and coming in sicker, and they're still, still questioning what's really going on. And we're trying to, the best we can present this information in a way that we're understanding that, hey, at some point down the line, you fell out of trust with the healthcare system. All the history is there to support that. I understand why that is and why that was. And I can't be mad at anybody for that. But here I am now. I'm trying to, as someone who, can relate to communities that you've come from, neighborhoods and houses that you've come from. Let me tell you what, what's really going on. Let me tell you what the science says. Let me tell you how we are going to, fight COVID and fight this disease and help you feel better. Let me tell you what I can offer you. And I just have to hope now that patients are willing to, accept the help and willing to be understanding and open to what we have to offer. But just as you guys were mentioning, it's a lot more convincing. We have to do a lot more convincing now while we're at work, which, while is a great opportunity to educate our patients and educate our community, it's starting to, I would say, take a toll on us as healthcare providers, right? Because that's just an extra burden that we have to bear, extra work that we have to do. Also, we are human and we get tired and run down and burnt out as well. So there's this fine line that we're walking. It's kind of dangerous on either sides, but we're doing our best to be, community educators in our respective spaces.
That's thank you for sharing that. It's such an important perspective. And I think even for those of us who are, community activists and not necessarily in the space that you are, it is important for us to continue to remind people that we ought to trust the science. We ought to trust the doctors. We ought to trust what has been studied and peer reviewed, and it's critical. And I think there's so much out there right now where people are just, my gosh, and I get it, right? Because this is new. I don't want to demonize anyone for their their concerns or their trepidations, but the fact of the matter is that this is what you all do, and as things develop, they will change. I hear people say all the time, I heard people say, and I was joking with you guys because both of you guys come from states down south where this whole mask and vaccination thing is like, they're like, we're done with this, leave us alone, But I hear people say, at one point, Dr. Fauci and the CDC, they said at first, don't use mask. And then they said, use mask. And now they've changed the kind of mask that they should use. And they went from 10 feet to 6 feet. And they went from 10 days of quarantine to 5 days of quarantine. And they went from the vaccine will protect you to the vaccine will just keep you from not being sick. And people get really confused, but also angry by that. But the truth is, this thing is evolving. And that's okay, right?
Yeah, exactly. As time goes on, we will continue to learn more about the disease. And I'm quite positive that things are going to continue to evolve and things are going to continue to change about how we handle COVID. Even from our end, the things that we do to treat COVID and treat symptoms of COVID and, the complications that can arise due to COVID are all going to continue to evolve. So I get the frustration. I get the anger. Trust me, I've heard it from my family included. But I think we just got to keep, like you said, things are going to constantly evolve as with other things in life, right? We're going to continue to gain knowledge on these things. What's important is that you have the right people in the labs, in the hospitals, in the, research towers, ivory towers, wherever they are, doing the important work of figuring out and like staying on the heels of this, deadly disease.
Yeah.
I think it's interesting because people, usually the public, is not following along with the scientific process as closely as they are with this. So this is how medicine always works. Things are always evolving, things are always changing. For instance, if you look at pap smears, the guidelines for pap smears change once every 5 to 10 years or so as we learn new information, as people get HPV vaccines, things like that. That's completely normal in medicine. That's exactly how things work, is that as we learn new information, as diseases change, as new treatments are available, things change. So I think for most people in medicine, it's really not surprising at all that there's been so many changes. But I think for people who aren't usually following along with that kind of scientific process, it can be really abrupt and feel kind of scary and feel like no one knows what's going on. But I think it's important to reassure people that the reason these changes are happening is because new information is coming to light. New studies are coming out all the time. New treatments are coming out. There's been a ton of new treatments that have been approved recently. And that's why these things are changing. They're not changing because people are being wishy-washy, but that can be really hard, I think, for people who aren't, usually involved in these processes to kind of come to terms with.
Gotcha. Let's go back to, I want to go back to big picture, because once again, this is Dr. King's week. We're giving Dr. King this whole week. This was not official, but here at the Far South Chicago Coalition, we're giving the whole week, the whole month, and really, in many ways, obviously the whole year. I want to talk about this quote that we heard in the video, which I really, really I love, and I think it's so important. Dr. King said in 1966, in basically he was speaking to a group of doctors, and he said, "I see no alternative to direct." Excuse me. He said, actually, that's the wrong quote. He actually said that too, but he said, "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death." And then he said, "I see no alternative to direct action and creative nonviolence to raise the consciousness of the nation with respect to the issue of healthcare." Healthcare is a civil rights issue. What you all are doing is on the front lines of social change and social justice. And I think it is so important that we recognize this. I want to give you a couple of data points around the disparities that exist in the U.S. healthcare system. Heart disease and cancer are the leading causes of death across the nation of all ethnic groups. And yet African Americans are 30% more likely than white Americans to die prematurely from heart disease. African American men are twice as likely as men of European descent to die prematurely from stroke. If you look at even the Native American community, has a mortality rate that is 50% higher than the mortality rate of people of European descent in this country. And then Native Americans have an infant mortality rate that's 1.5 times that of their European counterparts. And I think it's critical to understand, these issues. I bring up the race question because, and I'm still one last thing. African American women and Native American women have higher rates of stroke-related deaths than even Latino women and also women of European descent. These things are social issues. They are not genetic. And I want you all to speak to these disparities and your particular interest in sort of addressing, what piece of the disparity that, you're interested in. I want you to speak to those disparities in your work.
Yeah. The facts and the stats are always hard to hear for me, but it's good that we're keeping track of them, right? Because now more and more studies and more projects and more community organizations are getting a hold of these statistics and trying to do something actively about them, to combat them, to reverse them, to, turn that trend around in the other direction. For me, I see a lot of problem with, there's a lot of issues, and I don't think this one conversation will be able to cover everything that, is wrong and everything that leads to healthcare disparities and inequities in the communities that we serve. But one big one is access to healthcare. Access to good quality healthcare is something that I feel like leads to a lot of the like morbidities and mortalities that we're seeing that are disproportionate among African American people. So when we don't have access to primary care physicians, when we don't have access to stroke centers or cardiac centers or these hospitals that are, specialized to handle these things that are killing our people at disproportionate numbers, then of course we're going to see disproportionate deaths, right? If we live in areas that are deserts and as far as healthy foods, and also primary care physicians, again, in emergency departments, and parks that are safe to go on walks in and maintain your cardiovascular health. All these little things, when you don't have access to good environments, when you don't have access to the infrastructure that you need, that everybody, every human should have access to, then you'll see disparities, right? We have communities that are known to be deserts. We have known food deserts. We know that we have communities for the longest time. University of Chicago was not a trauma center, right? That trauma center is brand new, but most of our gun violence, most of our level 1 traumas, as we call them in the hospital, happen on the south side of Chicago. So you had at one point all of these victims of these tragic things and life-threatening, accidents having to travel more, just tens on the scales of 10 times the number of miles to a hospital that could adequately take care of them, when you have other populations that don't have to, struggle to get through that much traffic, that much time to get to a hospital, to get to a care center that could adequately take care of them. That's just one example of, how having access to proper healthcare helps with health outcomes. So one thing I'm super interested in is just access for our people. I think if we address that from the ground up, which is going to go to conversations and going to go to tables and round tables that I'm not a part of, discussions I'm not a part of, that goes to politics, that goes to the history of redlining, that goes to the history of the way our city is built, the way, that goes to all of that. But if we can sit down and create a community or create healthcare facilities for neighborhoods that we have already identified are at larger risk of these, strokes and heart attacks and these things that are ravaging our people, then that'll be a great step in, tackling these healthcare disparities. Again, that's just one of many different solutions that, we can address and we can try to work on. But access to adequate healthcare is one that I'm particularly interested in.
Dr. Leavitt.
Yeah, I think Dr. Coker hit the nail on the head. It's such a multifactorial issue. I think the good news is that there's been a lot of increased kind of engagement and interest in the medical kind of research system. So we're seeing a lot more research being published about these disparities, about why disparities are happening. We're seeing a lot of increased interest. But increased interest doesn't lead to change. So what we are going to really have to push for is kind of the next generation of healthcare workers is for the data that we're learning, the data that you talked about, to have change implemented. And that's so multifactorial. There's so many different things. A lot of it is social. It's access to exercise, access to food. In America being the country that it is, it's finances. There's a big correlation between the amount of money you make and your health. Unfortunately, it's not free to be healthy in this country. I think we all certainly wish that it was more of a right. And then, for me,
I'm sorry, I got to stop you right there because you made a point. I'm going to have you finish in a second, but you said it's not free to be healthy in America. And I was going to tap into the issue of poverty as well, overall, right? Obviously America has this very tragic history, and that has set up current conditions where a lot of the disparities are by race, but they also exist by class and income in this country. And to your point, if you cannot buy healthier food, which tends to cost more, if you cannot go outside and take a walk in a neighborhood where you feel safe and it's clean and those sorts of things, if you don't have, because you're working 3 jobs to survive, right, a situation where you can go to work, clock in, come home, have some time, these things all destroy our health. And so, we talk a lot about, these questions of poverty and inequality, and excuse me, and particularly healthcare. But if we were to create conditions under which people are able to just live and keep their head above water, it would do wonders for our health. Please continue.
Yeah, no, I think you're spot on. So a lot of this needs to be tackled at levels that are above what we can do in the emergency room, or what we can do in the hospital, or what we can do in a clinic. But I think, the things that I try to focus on, I'm someone who's interested in primary care and thinks that primary care is really important. Dr. Coker talked about access to care, and we want people to be able to find these preventative comorbidities before they cause problems. So we want to identify your high blood pressure before it leads to a stroke or before it leads to a heart attack, and start to treat people. So getting people into seeing a doctor a little bit more regularly, and then once you're in with the doctor, I think on our end, really working with you to make sure that you have medicines that you can afford and that you feel comfortable taking and that fit into your lifestyle. And, I also encourage patients to always advocate for themselves. So if I think a lot of patients, if they're not taking a medicine because it's too expensive or because they have side effects or whatever it is, just kind of, go about their life and don't take it. But I really encourage people to advocate for themselves and say, hey, like, this isn't working for my lifestyle for whatever reason, be it finances or whatever it is, and kind of encourage people to overcome that with their physician.
So what is regularly to you in terms of doctor visits? What do you recommend?
I recommend for pretty much everyone that you go at least once a year. If you are young and healthy, so that is generally going to be men who are under the age of about 35 or so without any conditions. You can maybe push it to every other year. Women, for your kind of annual women's health checkup, should be going once a year, be it to an OB-GYN or a primary care doctor. Either should be able to work. And then once you're kind of into that age of getting a little bit closer to middle age, so 35 and above, I would recommend once a year. Your doctor might feel comfortable pushing it out longer, but I would start with that. And the reason for that is, even if you feel well, a lot of these things that end up leading to these really devastating conditions, such as heart attacks, strokes, things like that, are they start off silent. So diabetes, you can't feel you have diabetes. High blood pressure, you cannot feel you have high blood pressure. You need these things to be checked by doctors with blood tests and vital checks, and to be managed by doctors before they get out of control and before they cause bigger problems.
Absolutely. So I want to press in. We've got some good comments going here. And we've been engaged in the immunization conversation from the beginning. How come we have 8th graders with no shots? I'm not exactly sure what to say on that one, or how that works. But I guess we talked last week in our show about children getting vaccinated. And the truth is that this question of vaccination has been such a hot topic right now. Dr. Coker, you are in the emergency room. And so you're seeing, I'm assuming, a ton of folks come in with COVID symptoms and things like that. Can you speak a little bit about the vaccination conversation? And then also, can you speak about kind of what's going on the ground in these emergency rooms during this pandemic? Can you give us, kind of what's happening?
Yeah. As mentioned, we were the group of residents who started our training in the middle of pandemic, right? It was crazy when we started, but it's definitely, I would say, in this most recent surge, gotten crazier, unfortunately. So it feels a lot heavier. We've seen with the new variant an increase in the amount of in how contagious the virus is. Whether or not it's as a severe disease, I'll leave that to the statisticians to come up with those numbers, because I don't have the numbers and I won't pretend like I do. But we're definitely seeing a lot more people come in with COVID positive cases, signs and symptoms, and we're having more admissions of younger patients with this most recent variant and this surge. So what that does to hospital systems is push them past their limits. When a hospital system is pushed past their limit, they stop functioning as they were built and designed to function. So we have we have understaffed departments, because just as our community members are getting sick and getting infected with COVID, we are in close contact with the first contact for the sickest of the sickest patients. So there's also going to be a couple cases for us, and we're getting sick as well. So we are short on staff. We have staff that are having to take extra precautions with their health as well. Our hospitals are very full. Our inpatient wards and our ICUs are to the brim. We're having increased waiting times, increased times to see a doctor, increased times to actually get in a room and see a physician in the emergency department. And as frustrating as that is on both sides, we're having a hard time doing anything about it, right? Because space is limited, and we have a very full hospital, quite frankly, at this point. So we've seen with this latest surge, our hospital have to stretch in ways that I don't think it was created to stretch, one, and also ever thought that it would be stretching or having to, try to compensate for the increase of patients that we're seeing. Now, when it comes to vaccinated patients versus unvaccinated patients, again, I'm not going to pretend like I have the hard numbers, because I do not keep a tally when I'm at work, and I don't have all the numbers, that although we do get weekly or daily emails actually from the University of Chicago regarding our numbers, I just don't keep track of it. But I can say from personal experience, and I would dare to say that my coworkers would say the same, we saw a drastic increase in unvaccinated COVID positive patients requiring inpatient hospitalization. My internal medicine colleagues can probably agree with that, because they're getting our admissions and they're being, also stretched to accept more patients than they probably ever have as well. And we're also seeing more patients become critically ill with COVID-19. So it's kind of disheartening. It's challenging to see. We have a lot of patients come in. I personally have patients who come in and they have their COVID symptoms. I'm more than, sure when I talk to them and see them that, okay, I've seen this before. This is probably COVID. I asked the question, did you get vaccinated? I asked the question, were you boosted? And I can say that a trend that I've noticed is that my more sick patients are the patients that are saying they were not vaccinated. I've stopped asking why. I don't want to get into that. I've stopped, trying to get into that, especially when somebody's having their worst day. I don't like to kick people when they're down. But that's definitely a trend that I've noticed. And I will say that everybody that I work with will tell you as well. More unvaccinated people are having more dire symptoms and presentations of COVID-19, which is pretty scary for us.
I will say, working on kind of more the inpatient side and the ICU side. So for one, our ICU is more full than it has ever been in my entire training. We're having to pull a lot of additional resources. It is way stretched beyond its limit. The patients who we are seeing in the ICU with COVID are almost entirely non-vaccinated. So the patients who come in who have vaccination, they sometimes, especially if they already have conditions that affect their lungs or their heart, they may need a little bit of additional oxygen and some inpatient treatment, and usually are fine and are able to go home. The patients who we are seeing who are really sick, who are on ventilators, who are dying from COVID, are almost entirely non-vaccinated patients. I'll also say I've noticed a pretty big difference between people who've gotten the booster and who haven't. So among the patients that are, needing some oxygen, kind of on the less sicker side, usually the patients who've gotten the booster do really, really well. That's not 100%, but that's overall what I've noticed, is that the patients who are boosted, have gotten their booster, are the ones who are doing much better. So they can still get the disease. It's not, at this point, the vaccines are not 100% against the disease. I'm sure you all know people who have gotten COVID despite being vaccinated, but once you're in the hospital, whether you're vaccinated and boosted really, really can dramatically change your course. I think, I still stand by the vaccination and the booster as the number one thing you can do right now to protect your health.
100%. And I'm going to echo that as well. we do know, and it's like you mentioned earlier, how there's all this confusion and frustration with administration, federal government, and CDC administration having kind of conflicting arguments against or for the vaccine and why you should get it and what's going to happen when you get it. I will say, as mentioned, you can get the vaccine, you can even get the booster, and you can still become COVID positive. But there is a huge difference in what COVID looks like for a vaccinated patient versus a non-vaccinated patient. There is still a huge difference in what COVID looks like for a vaccinated and boosted patient versus an unvaccinated patient. So that booster is offering the level of protection it is advertised. It is not 100%. You could still feel bad. It's still not fun. COVID is not fun for anybody who gets it. But the outcomes and your length of stay in the hospital and your chances of life-threatening illnesses and complications from COVID are still reduced with the vaccinations. And that is why we as physicians stand with the vaccinations and the booster.
The most recent data that I've seen is that getting vaccinated and boosted compared to somebody who doesn't have a vaccine, you are 68 times more likely to die. 68 times, not one or twice, more likely 68 times more likely to die if you are not, if you are unvaccinated compared to vaccinated and boosted. And that's what I'm seeing. I mean, the people who are really sick, the people who are dying are almost uniformly the people who are not vaccinated. Again, it's not 100%. There are people who have a lot of baseline conditions that make them very susceptible, but it's the people in the ICU who are really, the patients we're really scared about are almost always non-vaccinated.
Wow. I'm going to hit a couple comments. This is actually, I thank you all so much for what you just shared. I don't think we can say this enough. I really don't. I don't think, I mean, I think if people were on TV every day showing what's going on in the hospitals, every day talking about this, I don't think it'd be enough. And I've, dealt with a few family health issues recently, and we recognize that, the family member who was not able to get a bed, because of what's going on and had to wait. And, these are real things that we've never seen in America. We've never seen this kind of run on the health system, and to really stretch the healthcare system in a way. To your point, it is so critical that we do our part to relieve the burden, because this is a real a tragedy in many, many ways. So I want to hit a couple of the comments here. We're going to wrap up in a few minutes, but how much do diseases like diabetes and strokes and high blood pressure that are prevalent in African American communities impact the rise of COVID in these communities? Is one of our questions here. So, either any of you could answer that question.
Yeah, so I think there's a lot of developing data, and I think data will continue to, kind of like we talked about before, we're always learning more and we're always studying more. New data is coming out all the time. But what we are seeing is that there is a significantly higher chance of a poor outcome of, morbidity, of mortality with COVID if you have some of these underlying conditions like diabetes, strokes, high blood pressure. And we also know, like we talked about, those conditions are significantly higher in populations that don't, that traditionally don't have the access to healthcare. So patients of color, patients who are below the poverty line are more likely to have these diseases. So yeah, I think that's contributing to the worst outcomes that we're seeing with COVID, 100%. I don't want anyone who has those diseases to be living in fear. But I just want, for people who have those diseases to really think about, for people with diabetes, stroke, high blood pressure, your immune system doesn't work quite as well as it did, back when you were 20 with no health conditions. And it's extra important to get the vaccine at that point.
Yeah, absolutely. There's a question about the collection of data and who's collecting data. I want to just refer to the numbers that I shared earlier from the CDC. And, I don't know if we want to get into a conversation about sort of data collection and that sort of thing. I mean, if you guys had any thoughts on it, I'd be open to it. But I would love to hear. Actually, what do you guys have any thoughts on that? I guess I could at least stop and ask the question. Do you guys? I'm assuming that, and correct me if I'm wrong, that you guys, don't spend a ton of time sort of thinking about where the data is coming from in that way. Kind of, I would imagine that. Is
Um,
that a fair assumption?
no, yeah, you're right. We don't. I'm pretty sure
Yeah.
our first priority is seeing and treating our patients.
Yeah.
But with the systems that are in place, there are public health teams that collect the data that we get, of course,
Yeah.
unidentified. Sometimes identified for public health issues and
Mhm.
spreading issues. But patients who test COVID positive, there is a database that does keep track of everybody that comes in, tests positive, has symptoms,
Sure.
and
Sure.
follows their track in the hospital. That's, of course, how we get our numbers about who presents with COVID in the ED and goes to the ICU versus goes home versus goes to the floor. We keep track of that kind of data. Pretty much, I would say all hospitals around the country are doing it since we're collecting data for the CDC. This is how those numbers are
Sure.
developed, and these are how those
Sure.
numbers come about. So the data is being collected. I would say it's being collected in a responsible way.
For sure.
This is not unlike what we do for new cases of HIV, syphilis, and other sexually transmitted infections that are also public health risks.
Gotcha. What would you say is the most common thing that you see in the emergency rooms right now?
COVID. COVID. So symptoms that we're seeing, I'm sure everybody by now knows the symptoms of COVID, but it won't hurt going over them again. Most commonly being like a dry cough, and then some having a fever. The most specific sign that we've had in the past since the pandemic started of a positive COVID-19 infection is like a
Yeah.
sudden loss of taste or smell. Not seeing that as much lately, to be very honest with you. I am just seeing more of the shorter breath, fevers, and this dry cough that is nagging in
Sure.
multiple ways. Also correlated with some recent exposure. So whether you
Yeah.
were doing something on a larger scale of, being at an event, a social event, or large social gathering, a family party. I'm seeing a lot
Yeah.
of those, especially with it being recently the holidays and stuff like that. And also being colder weather. So we're all gathering indoors a lot more. So we're seeing
Yeah.
that correlation with large gatherings, and then 5 days to a week later coming in, like I just can't
Yeah.
catch my breath. I just feel super fatigued and super weak. So those kind of symptoms is what brings most
Yeah.
of our patients to the emergency department.
Yeah,
And I do
thank
think
you. I mean, I'll let you answer the question. I know it was probably a very obvious question since we've been talking about this whole time, but I think it's important for people to remember that we talk about gun violence in the city and we talk about all these various things. Day to day, what you are seeing mostly when people walk through the emergency room is still this issue, this disease. And I think it's so critical that we reiterate that point. Go ahead, Dr. Leavitt.
I was just going to emphasize on the outpatient side of things, of people who are not sick enough to go to the ICU, the most common symptom right now is sore throat with Omicron and the
Yes.
variations that are running around now. If you have a sore throat, there's a decent chance that it's COVID. So that doesn't need to go to the emergency room, but that is something that you would either need to isolate or get tested for.
Gotcha. I'm gonna take one more comment, and then we're gonna bring Dr. Roberson. Actually, I'm gonna bring her in now. I like to bring her in early. She comes in and closes us out. But these conversations, I mean, this conversation has been great and so needed from practitioners who are on the ground, folks. If you don't listen to anyone, please listen to these doctors, please. I got another question, and maybe we'll close out with this question and then sort of close this out altogether. But, I asked the question, how close do you work with community health needs, assessment requirements? And do you know any partners of community health needs assessment requirements? I don't know if you guys are familiar with that, if you want to speak to that at all.
I think our Community Champions program is a great example about how there are whole departments and whole organizations within the University of Chicago's system, and I'm sure outside of our hospital system, whose job it is to assess what our community needs and where we're lacking, where we're coming up short, where that mistrust is still stemming from, and what we can do to help that. So there are people, I think that's beyond while that is probably both of our interests, being that we're both, Dr. Leavitt and I are both community champions, and we both, sought out this opportunity. Our job, like I said before, is mostly treating and seeing patients in the hospital, and in Dr. Leavitt's case, in the clinic. But there are definitely people whose sole job is to assess community needs.
Yeah, yeah. I thank you for that, because you're right. You all, sort of, that's not your day-to-day job every day, but it is so cool to have you in this space, because a lot of folks don't get to talk to you unless they're seeing you, right?
Mm-hmm.
And so to know what you're doing and to understand it, I really, really, really appreciate it. And I'm really excited that you guys have this program. And I really hope that you're able to get in front of more folks, because, as you would probably tell me, because you know this better than I do, an ounce of prevention is worth a pound of cure when it comes to these health issues. So, Dr. Roberson, I'm gonna bring you in if you want to say anything to our panelists and all, but we'll let you close us out here. And so please come on, join the party. All right, we lost your audio. I don't know what happened, but we cannot hear you, unfortunately.
Okay, there
There
we
you
go.
go.
Okay, well, I wanted to say, wow, what an excellent job, and I want to excellent show, and I want to give a special thanks to you, community champions, and we will definitely have to have you back.
Thank you. I appreciate it. It was a
Absolutely.
pleasure
Thank
being
you.
here.
And before you guys leave, if there's one thing that you want to close out with, in terms of just if people could hear anything, if they can hear one thing, I teach, and so I always tell my students, if you don't hear anything else I say today, just hear this one single thing. Just hear that. Can you guys give us that one thing before you go?
I mean, I think I've said it already. I'll say it again. I think right now, living in this pandemic, the absolute number one thing you can do to protect your health, get a vaccine and get the booster. Tell your friends, tell your family, tell your loved ones, tell your neighbors, as many people as possible. It will protect you. It will help end this pandemic faster. It will protect the hospitals. It will protect everyone else. It's, I think, my absolute number one recommendation as a physician right now.
Thank you so much.
Same, 100%. I back that 100%. But also, I would encourage people to, if you haven't seen a doctor in a while, this would be the time to reach out to your friendly primary care physician, and go ahead and try to schedule that appointment. Try to get a checkup. And when you're there, or if you happen to be in the emergency department, God forbid that you have to come there. But if you do, and that's your first line, that's fine. That's what we're there for. And we understand that is people's sometimes only option. Ask questions. Whatever you're interested in, whatever you have a question about, if you're still uncertain about this vaccine, if you're uncertain about one of your medications, as Dr. Leavitt was saying, ask us questions. Be inquisitive, be an advocate and a champion of your own health, of all the ailments that you're feeling. Let us know. Be open with us so we can help you more. If you hide or withhold information, or scared to ask us questions, or for some reason don't want to open up to us, then it limits how much we can help you. And we truly do want to help. There are great doctors out there that really do want to help you and really do want to get you the best care possible. So just be open with us, ask us questions, and we'll do our best to be as open with you and honest with our responses.
Fantastic. Thank you again, Dr. Leavitt and Dr. Coker, for taking time out of your day and your busy schedules to join us and really educate the public. What you do is, as Dr. Roberson said, you guys are community champions. You are community leaders during this season, and we wish you the best in all of your work. Thank you guys so much for coming.
Thank you.
All right. That was good, huh?
Yes, it was excellent.
Absolutely.
Well, that concludes our Friday Health Talk of the Week. Wow, what an excellent show. And I want to give a special thanks to our community champions, and I will definitely have to have them back. Health is one of the most personal and intimate parts of everyone's life, especially today. So we all should be able to trust our doctor with whom we discuss our medical conditions. Talk to your doctors about your health concerns and be truthful, and ask questions about any physical evaluations that they perform on you, and follow their recommendations. And listeners, thanks for joining us. Remember, we want to hear from you. We want to invite you as a guest to give comments about the Far South Chicago Coalition. If you've been influenced by our show, or if you have any comments, please call us, visit our Facebook Live, like us, comment about this Facebook, and request a show topic that you would like to learn more about. This show is sponsored by the Health and Mental Wellness Committee of the Far South Chicago Coalition, which is spearheaded by our president, Dr. Joyce Chapman. This show is directed and the content was produced by myself, Dr. Tonya Roberson, and a job well done by our moderator, Mr. Ted Williams III. We look forward to seeing you all next Friday. Have a great weekend.